So today we talk a little bit about the mechanical ventilation aspect in ARDS, or the aspects that come with it. There's no particular way to ventilate an ARDS patient. Some people talk about high-end APRVs. Some people talk about just SIMV. Certain centers only use volume control. You mention pressure control and the consultants start jumping up and down. Some want to talk about bi-level ventilation. But how come there's no fixed rule to mechanical ventilation? I tell you, there's none. And if you see that most trials that come out that talk about mechanical ventilation come from the Europeans and generally the Italians. You look at the Brits, they don't talk about it. The Brits focus on sepsis, they focus on ultrasound imaging, they focus on basic physiology. But when COVID came out, you see a lot of the Italians, you talk about Amato, Giatinoni, they're all Italian names, right? So the Europeans are generally stronger, or they do more research in mechanical ventilation. But that being said, there's nobody who agrees with each other 100%. So we talk a little bit about ARDS. So the agenda today, we introduce ARDS, which I'm sure is not unfamiliar to many of us here. Then we talk a little bit about the mechanical ventilation, and then if you have any questions, we can discuss, or if our other colleagues have any approach to how they look at ARDS, we can be happy to just listen to what each other has to say about it. So you look at this X-ray, not uncommon. Most of the time you see straight away, you say, oh yeah, this is bilateral infiltrates, ARDS. So in the 1960s, it was first described as hypoxic lung injury, can do to infection or trauma. And they realized it's very similar to the neonates who had congestive atelectasis. And more, they realized the mortality rates begin to approach 50, 60%. And many come in critically ill. So for more than 20 years or thereabouts, there was no common definition of ARDS. So, you know, in the ICU literature, they published, then they say ARDS can be up to 10% all the way to 90%. So in 1994, they started to come together and say, look, we need to come to a consensus. So you see the epidemiological studies, there's a whole lot, and you will see those who are involved in the management of ARDS, you see many names that are familiar to you. John Louis Vincent, Bernstein, Ruben Esteban, all these are big names in ARDS or even intensive care. So in 1994, the American and European guys, they thought, okay, come, let's sit down and have a consensus to say which set of patients or how do we identify ARDS. So they started in 1994, and after that came the definition that we are familiar with, right? Berlin's criteria. So Berlin's criteria in 2013, they came together and they said, look, let's classify them based on their level of hypoxemia. So mild, moderate, and severe, based on timing, based on infiltrates, and based on severity. So this will be easier if you want to be more familiar with it. Okay? But there are a few problems with Berlin's criteria, right? The Berlin criteria. Most scoring systems or criteria have the same problem. So ever one day you want to sit for your postgraduate exams, they ask you what's the problem with scoring systems. Then you realize they are all nearly the same. You want to talk about your criteria for severe acute pancreatitis? Same. The problems are the same. What are they? You cannot predict mortality. You can say it's severe, yes, but it doesn't tell you the etiology of whatever is going on. It doesn't take into account whether a patient is on pressors or not. And compared to autopsy, where diffuse alveolar damage is the gold standard, how are we going to compare? Does it allow us early identification? By the time you use this criteria, they're becoming quite poor, right? So how are you going to identify who's going to get it first? And does it really apply in real world scenarios? Does it apply to you and me? Does it apply in the United States, or does it apply in the deepest ends of Africa, maybe? And between the X-rays and CT scans, there are such big discrepancies. You know that clinically, your X-ray is going to lag behind your clinical manifestations. So how are you going to relate everything? So early this year, people start to talk about this new global definition in the American Thoracic Society. But why is it not popular? Nobody cares. Why? But you need to know, if you're going to sit your pros primaries, if someone asks you, you need to know that, oh yeah, people did talk about a new definition. And what was the new definition? They included certain parameters. And one of the things you see is that they included parameters for non-intubated patients. But what's the problem now? The problem now is that everybody has ARDS. So how? Anyone who has put on NIV has ARDS. A little bit of lung infiltrate, ARDS. So who has ARDS now? So everyone you see has ARDS? And it never became popular as far as you talk to the top people in the world, they don't use it because it's not it doesn't apply so much to us. And the other thing is that some patients, they use pulse oximetry to identify hypoxemia. But what about countries that are resource poor? So how are you going to identify them then? So how are you going to classify them, right? So we go to the risk factors of ARDS. So if ever you ask a question, what the causes of you, of course, you're going to say lung-related, non-lung related. And in our setting, the most common of non-lung would be sepsis, right? So a little bit about the pathophysiology of ARDS. If you ask, traditionally, we know there are three phases, right? The exudative, the proliferative, and the fibrotic. But more and more, we are seeing less of the fibrotic phase. Why? So that brings us to our topic today. Is it because the fibrotic phase is caused by us, in that we are not ventilating our patients properly? Or is ventilation the only problem that comes with it? Okay, so all these not so important. We go to our main topic for today. So what's the role of mechanical ventilation in ARDS? So we want to restore gas exchange, right? We know that the big problem with ARDS would be shunting. You want to improve survival when they are severely hypoxemic. You want to prevent secondary lung injury. And you want to make sure that you minimize side effects. We've learned so much in the first talk about the complications that come with improper mechanical ventilation, right? Even as simple as obstructive airway disease. So what are the problems though, the challenges when we want to ventilate a patient with ARDS? Tons of problems, right? From lung compliance, ARDS patients normally have poor lung compliance. Ventilator settings, we know how to set our ventilator settings. Hemodynamic changes. We learn about dynamic hyperinflation of the lung. It doesn't just apply in obstructive airway disease, even though it's more pronounced, but it can also apply in any patient that's intubated. So a common question is, what are the causes of hypotension post-intubation? Dynamic hyperinflation of the lung is just one of them, right? There are so many causes. Even the drugs you use to induce the patient can be a cause of hypotension, right? So the concept of ventilation or ventilator-induced lung injury, we can see what happens. It's due to volume trauma, atelectotrauma, can be barotrauma, it can be biotrauma due to opening and closing of the alveoli, and in the inflammatory cascade is activated, and a whole series of events occur. And it not only affects the lungs, but it can have systemic manifestations as well. So it's called a spillover effect. So we talk evidence today. So what are the modalities that have evidence to it? So the first would be the lung protective ventilation. What's the purpose of it, right? We want to prevent over distension or stretch of the aerated lung. And more we realize that stretching the lung too much is the cause of lung inflammation. So in the 1990s towards the early 20s, a lot of work was done, and you would have heard of the ARDS net or ARDS network. You've heard of Amato et al. These are names that might be familiar to you, but it's based on the strategy of maintaining low inspiratory driving pressures, okay, and accepting higher partial pressure of carbon dioxide. So is carbon dioxide dangerous? Yes, it comes with a whole slew of manifestations like we learned just now, but CO2 per se doesn't kill. Our COED patients come in with a CO2 of 150. Our ED colleagues intubate and send to us, we win, right? Extubate, right? And more we are learning that mild hypercapnia may potentially have neuroprotective properties. So it prevents apoptosis of your neurons. Some intensive care units in Malaysia, even traumatic brain injury, we allow a CO2 of up to 50. Right? We don't do this 35 hyperventilation kind of thing, unless you have an endpoint. But not all our neurosurgical colleagues will agree with that. So in my unit, I kept it at 40. You're not allowed to go less than 40 to 45. You go less than 40 only if you have an endpoint to your hyperventilation. Okay? So what's the concepts of lung protective ventilation? So these three things are things you just want to know about. Right? So hypercapnia and respiratory acidosis, they're actually well tolerated as long as the patient is well oxygenated. And that our biggest example would be our asthma and COPD patients. Right? They come in as long as it's not a congestion issue, not a pneumonia, but a pure obstructive airway disease. Well, some even tolerate CO2 of what? Unrecordable. You've heard of incidences where they come in, your ABG, your CO2 not recordable already. Bypass your point of care ABG machine. But you intubate, hemodynamics okay. After a while, you win. Maybe need a trachea, not for asthma, COPD patients. And they do well after that. Right? So, mechanical ventilation, if you're not careful, we know if you remember your pressure volume loop or hysteresis, where your inflation, inspiration, and expiration. Now, more and more, we realize that recruitment and de-recruitment occurs along the whole length of your hysteresis curve. So where is the point that you want to target is still up for debate. And the third is the concept of what we call the baby lung. And again, this was popularized by Jatinoni et al., where they did a series of CT scans, and they realized that in ARDS patients, the lung that is normal is only the equivalent of a 5 or 6 year old. So that is why your low tidal volume ventilation comes in. You're not going to ventilate a patient like you're going to ventilate me, big buffalo, right? But you want to make sure that you're not destroying whatever lung is already there. So you see how the whole cascade of mechanical ventilation occurs, right? So on one side, you have your volume trauma. On the other side, you have your atelectal trauma leading to pulmonary edema, alveolar capillary damage, reduced lung compliance, and then you have your ventilator-induced lung injury. So in 1998, Amato et al. Predicted a 30-day mortality of patients with lung protective strategies, so-called. And for those that use this low tidal volume approach, the mortality rate dropped to 38%. But for those that use a conventional tidal volume of more than 10 mils per kilo, the mortality rate was about 70%. So how do we titrate then? Some might be familiar with this protocol that was produced by ARDS net, what they said, you use low tidal volumes, but you use high PEEP. And this is very popular. Everyone looks at it and then they got titrate it based on this PEEP. But you look at the PEEP, it's super high, it goes up to 24. And this comes with a whole lot of issues as well. So a big trial that came out called the alveoli trial that used even higher PEEP titration, and they found out that actually it doesn't improve the outcome so much. So high PEEP versus low PEEP, the mean days on ventilator support was nearly the same. So again, we saw evidence, big trials, right? ARMA, Express, they talk about PEEP titrating strategies. And again, there's not one that is more robust than the other. So what methods did they use? How do they find optimal PEEP? So you see, based on this slide here, there's easily 5 to 10 ways of people trying to get optimal PEEP. Some use straight away, start with a high PEEP. Some use the ARDS net table with your PEEP FiO2. Some titrate according to compliance. Some based on the pressure volume loop and say, oh, let's keep it a little bit above the lower inflection point, which is what we are familiar with. Some use a stepwise recruitment. Some base it on your ABGs and your AA gradients. So some use CT scans. So what do we do then? To be honest, we don't know. So when do we have optimal PEEP? It's when oxygenation is maximized, there's minimal atelectasis, and there's minimal overdistension. That's all we know, right? So what are the influence factors that influence all these? Again, it's up for debate. So now that was optimal PEEP. Now we talk about driving pressure that you heard. So what is driving pressure? Driving pressure was introduced by Amato et al. To say that good outcome is not based on PEEP, it's not based on small tidal volumes, but it's based on the pressures that are used to open your lungs. And what is driving pressure if you use volume control? It's plateau pressure minus your PEEP. So how do you get plateau pressure? Yeah, I'm sure after the first lecture you don't know, then Dr. Ashraf will stand up and say, answer his questions again, right? So they said if you normalize your tidal volumes based on predicted body weight, it doesn't take into account that the lungs are all heterogeneous. It's so different. So you're basing it, assuming that, okay, there's this portion of lung that is viable and the rest are diseased. So how do you actually have a directed goal when you set your ventilators? So Amato et al. Predicted and said, look, if your driving pressure is less than 15, the outcomes are quite good. So what do you do then? So to get your optimal driving pressure in ARDS is very difficult. So how do you adjust your ventilator settings, or what are your parameters that you can adjust so that you can achieve a better driving pressure? So the list here, you can reduce your tidal volume, you optimize your PEEP. Potentially, you want to use recruitment maneuvers, which are a little bit controversial. You want to use neuromuscular blockers, blocking agents. You want to put them prone, or you want to use extracorporeal measures. Okay, which leads us to recruitment maneuvers. How many do recruitment here without your specialist knowing in the middle of the night? When your ARDS patient comes in, say, ayo, saturation 60 lah, EF ratio 50. Before I call my pakar, I heard of this lah, let's push up the PEEP to 30 for 30 seconds. Ada? Sure got lah, cannot bluff me lah, I also used to do that. But is there any evidence for it? What are we trying to do? So we increase our airway pressures for a short period of time, hoping to expand our collapsed alveoli, right? And this is based on the principle of fast and slow alveoli. So for exams, time compliance in your alveoli equals to time constant, equals to compliance times resistance, right? So you have your fast alveoli, which expands really quickly, and slow alveoli that's very hard to open up. So when your alveoli is collapsed, that first breath to open up is the hardest. Once it's open, then it's okay. But what happens when you have diseased lungs and normal lungs? If you're not careful, or if the lungs are not recruited, what happens is your alveoli opens up. Before these slow ones can open up, you're already exhaling. So you don't get extra oxygenation. So it's the opposite of obstructive airway disease methods of ventilation. So what you want to do is for the alveoli to open up and allow it to equilibrate, to open up the closed alveoli, and then you keep it open with PEEP. So that is your goal of ventilating someone with severe oxygen failure. Okay. So and you aim for better gas exchange. So how do we rationalize what we do? So we know that in mechanically ventilated patients, there's many elements of de-recruitment, especially if once you intubate them, you know that they get atelectasis, you send a patient for trachea in OT, you come back, suddenly your ventilator setting from FL 2.3, you come FL 2.7, and then you win again. Because there's all de-recruitment and atelectasis, right? And most have low tidal volumes, maybe your PEEP touch cope, or you're using high FiO2s, which causes absorption atelectasis. So what we aim is to open these collapsed alveoli and to use PEEP to prevent the alveoli from recollapsing. Okay, so this is a diagram of what I was talking about. So recruitment, de-recruitment occurs along the whole length of your hysteresis curve. A lot of people are trying to find the optimal PEEP. We've even got high-end modalities like transesophageal manometry to predict pleural pressure, because we want to have calculate our transpulmonary pressure, which is our driving pressures. But these are not things that we do in our setting, and not every center has. If you come from a research center that does a lot in mechanical ventilation, okay, wow. But what about us? So how do we know where we actually stand? So traditionally, we always thought that you want to keep your PEEP above the low inflection point. You want to keep it at the steep part of your curve. If you go too high, they're over distended. So whatever you do is not going to make a difference already. Your lungs are this big, right? If you're too low along it, your lungs are collapsed and you cannot ventilate. So you want to keep it just along the low inflection curve here, and you want to keep it along this area. And in expiration, you don't want it to go below your point. Okay? So this is your point of maximum curvature. If you go anything below that, then the lungs start to collapse again. So in terms of physiology, when we intubate the patient and normal tidal ventilation, there are three distinct lung zones that are produced. So there's the dependent area that is collapsed throughout your tidal ventilation. So it causes chronic collapse injury. There's this intermediate one that opens and closes and opens and closes, and that's where your atelectal trauma comes in. And then your least dependent one that's right on top of the high end of the pressure volume loop. And that's where your volume trauma and barotrauma occurs. Okay, so this is just a diagram to show what happens, and you can go into multi-organ dysfunction as well. So what's your advantages and disadvantages of recruitment maneuvers? So advantage, you can improve your gas exchange, compliance, it's cheap, it's easy, middle of the night, nobody kacau you go and try. Jadi ke tak jadi, never mind. You just try it. They say, oh, if it works, then great, I've achieved something. If it doesn't work, then you call and say, boss, doesn't work. Or no, you never admit. You say, boss, cannot, terrible. Then your boss comes and does the same thing you did like 5 minutes ago and has the same outcome. And then you say, yalah, memang not recruitable. Boss pun tak boleh, I pun tak boleh, okay lah. Right? So, but what are the disadvantages? You need sedation, paralysis. The benefit, is it really permanent or is it transient? Hemodynamic instability. More and more, I'm sure Dr. Hidayah will be able to tell you later, we're looking at the right heart. So in ARDS patients, 50% of them will have some right heart strain, or even more, I think, around there again. And then if you see your so-called D-shaped septum, interventricular flattening of the septum, then you think, oh, is it pressure overload or volume overload? And then you go into all the things. But ARDS patients big part of them are going to have a right heart issue. So if you are going to recruit and give them high thoracic pressures, you are going to increase the right heart afterload, and you're going to exacerbate right heart failure, right? So what's the evidence for recruitment maneuvers? It's actually conflicting. And the ART trial 2017, the FILAP trial in 2019, the ART trial said, oh, okay, improvement a little bit, but mortality increased. And the FILAP trial in 2019 showed that there was increased risk of dysarrhythmias. So what's the outcome? No improvement in mortality, maybe improvement in oxygenation, reduced use of rescue therapy, but then there's increased rate of hemodynamic compromise. And again, when we talk about trials, we have to be very careful in what we accept. So how do you appraise a journal? I tell you lah, tengok abstract, tengok conclusion, and say yes, applies to me. Betul tak? One thing you must remember that many trials are what we call pragmatic trials, cause and effect, cause and effect. So they do this and look at, so big example like COVID. We came up with tocilizumab, IL-6 inhibitors, and then some use anakinra, and finally dexamethasone. How do you know that this is the minimum amount of dexamethasone needed for this patient? How do you know that this non-responder might not respond to maybe 50 milligrams of dexamethasone? You don't know, because they are cause and effect trials. So they give you a standard dose and they look at the effect. So you say, oh, 10 milligrams of dexa. Oh, fine, we all accept that. But how do you know that maybe I am a responder to 50 milligrams and you are a responder to 10? I don't know. So we need to be very careful in taking trials at its face value. And again, I'm not an academic, and I really shouldn't say this on public, right? Journal appraisal is not a strong point of mine. But my exposure has brought me to see that what the journals write, or what you see in the main body of the journal, is what the authors want you to read. But the hidden parts are in the appendix, in the statistics, and you need to have a mind, the correct way to read it, which I don't have. So I trained in a center that actually had a team to counter all these journals that came out. So if you realize in COVID, Yatin only came up with a lot of things. But there was this group led by this guy called Tim Snow who was responding. Ding dong, back and forth. Tim Snow was from UCL, UK. Then I got a chance to go there and meet them. And I realized Tim Snow is actually younger than me. He's an intensive care trainee who's doing a PhD as well. And he was in Mervyn Singer's team. And Mervyn Singer is the famous author of the Oxford Handbook of Critical Care Medicine. Right, sepsis 3, all that, he was the lead. So he was my direct boss. And that was where I found out that they have a team to query other people's findings. So there was a lot of back and forth. And again, it opened my eyes to say that, I better not say I know how to read journal. I totally don't, put in a situation like that, right? So be careful when we take trials. Let's say our nutrition trials. Many of our nutrition trials are done in first world countries. So how do you know that their nutrition requirement is the same as us, or is the same as low resource countries, right? How do you know that our makeup is going to be the same? How do you know, and when they talk about severely ill, their severity might be different from us. Because in the first world countries, anyone who's on pressor and NIV comes to ICU. In Malaysia, we have to apologize to our ED colleagues, say, sorry, I cannot take in yet. Katil tak ada. And already on what, so how do we correlate that? So we need to be very careful. All right, so this is another thing to consider, in that ARDS has many phenotypes. It doesn't mean that ARDS is a one-size-fits-all. You have inflammatory phenotypes of ARDS, which is most of the time due to sepsis, or you have the non-inflammatory type, can be due to pneumonia or lung potential respiratory cause. You can have some that are focal or non-focal, severe, moderate. You see, there's so many recruitable responders, non-responders. So what are we dealing with? And most literature will say that lungs that can be recruited in severe ARDS are maybe 5 to 10%. So recruitment maneuvers potentially is not evidence-based, and we are causing more harm than good. All right. So you see, many studies come out talking about the efficacy, and you will see that the names always repeat in these studies. So recruitment maneuvers not supposed to be done routinely in the management of ARDS. It can be done by clinical experts, and different people have different ways of doing recruitment maneuvers. I personally use what is called the Lackman's method. Some use the stepwise recruitment. Some use ARDS net tables. But we realize that mechanical ventilation now is not just about oxygenation. It's more about prevention of secondary or your VDs. Now, prone ventilation. After COVID, everyone pakar proning, right? You just close your eyes, the nurses come, wrap the fella up, pop, prone, finish. Some centers, I think Ashraf's time in Sungai Buloh, 5 minutes, your fastest proning. You just say prone, and 20 people come, and then you turn around, the patient prone. Right? So, what's the evidence, and why and when do we use it for these patients? So what's the benefit, or what's the physiology that comes from it? So we first talk about lung compression. So when you put a patient prone, the weight of the heart doesn't press on your lungs, right? Improves your right heart forward flow. And it also improves your transpulmonary pressure. So the pressure required to distend your lungs. So it becomes more that means it's more equal or equilibrated, and it's not just to single areas of it. Important ventilation perfusion. So remember your lung physiology. Areas of perfusion are best at yes, your bases and your dorsum, your back. And is it gravity dependent? No, it's not. Whereas your areas of ventilation are. So you have expanded alveoli on top and your collapse at the bottom. So what happens when you prone the patient? You put the patient face down, your perfusion is maintained, but your ventilation is improved. So your collapsed lung has now gone to the top, where there's good blood flow. But the lungs that are going to collapse will collapse at the area where blood flow is never good anyway. So that is how you improve your shunting, right? So chest wall compliance, generally your chest wall compliance will reduce because you are flat on top of it, right? Your bucket handle effect is reduced. How about lung compliance? So overall compliance actually will be decreased, but a lot of it is based on your alveoli that is recruited. So if your alveoli is recruited, your compliance can actually be balanced out and potentially improve. So you just look at your plateau pressures or tidal volume after you change from supine to prone, and then it will show that the lung is potentially recruitable already. Just very simple. Just put them prone, and then you see, hey, your numbers improve. That shows that, just that simple maneuver shows that there are areas that are already being recruited. Okay, and then you reduce your risk of ventilator-induced lung injury, right? So reduce over distension, maybe you reduce your PEEP, reduce the effect of your small airways closing. And we cannot do without a big trial. So everyone knows Proseva trial by Gurin et al. Minimum how many hours? 16, right? So some of my senior consultants used to tell me, if the patient has been supine for 1 week, they're going to be prone for 1 week. That's the amount needed to get their lungs back. So how you want to prone, up to you. We've done, in Penang at the time we've done more than 24 hours proning, and then we flip them back. And then the total length of proning is equivalent to the total length of the patient supine when he was in distress. So is that hard and fast? Again, there's none. And when COVID hit, that was what we did. And so Dr. Chin was also, we trained under the same consultant, realized that things work, right? So early proning makes a difference. Okay, now we come to neuromuscular blockade, right? Dr. Ashraf also talked about it. Increased risk of what do you call that? Myopathies. But is there any evidence? Lots of trials. Those who set for exams need to know. The main two trials are, I think I asked. Nadia, accuracies and ROSE, right? So all those who sit for your anesthesia exams later, you need to know these two trials. Where they use neuromuscular blockade, accuracies show that, lung ventilation improved. But the problem with it is that everyone was so caught up with the good outcome that they forgot that it was a very small trial and it shouldn't make so much difference. So when ROSE was initiated, they realized that there's no significant endpoint difference. So what you want to take from it is that there's no evidence to support early or routine use of paralyzing agents, right? So they might show an improvement in a subgroup with those who require very high sedation. That means there's either very bad dysynchrony or the lungs are so bad that you need to sedate them very thoroughly anyway. So potentially these are the people who will benefit. Then of course, conservative fluid strategy. So the two big trials in critical care, fluid trials that we need to know, one is the FACT trial. So it showed that conservative fluid therapy has better outcome than liberal fluid therapy. So more and more we are using many modalities to direct our fluid resuscitation. It's not like in the old days where you want to just write 30 mils without thinking. Right? Okay, we're nearly at the end. We talk about a few other things that people sometimes talk about. HFOV. In the old days, very popular. You have it, Pete still uses it. How do you know whether it's good? You go put your hand there, pop, the patient kicking away and say, working, right? But they realize that the evidence doesn't support it. So nearly every center, we don't use it anymore. The machine is in the storeroom. And then Pete will borrow it from us once in a while. NIV in ARDS, is there a role? I think we need to be very careful. What is the problem with using NIV? What is the biggest problem with using NIV? What? Yeah, correct. You put them in the ward, patient is on NIV, okay, no need to jaga. We go jaga the one with the non-rebreathing mask first. Right, like that, you go medical ward, especially, you plonk the patient there on NIV, your review people will say, patient already on oxygen support, never mind. But patients on NIV, again, I will quote Tai Ling, you must review them within the next 1 hour and decide whether you're going to intubate or not. If there's no improvement, you need to make a decision. You cannot leave them on NIV for the next 24 hours without a plan, right? So in the first world countries, NIV all in ICU because you need to decide, are you going to intervene or not? But our problem in our resource kind of setting is that, not intubated, no choice. What to do? Then we worry about them later. Okay, then big topic, APRV. Very fancy name, right? Using the principle of inverse ratio ventilation. So you put the patient, it has to be spontaneously breathing, put them on high PEEP, pop, with a very short release so that they don't lose their PEEP straight away. Any evidence? Improvement in gas exchange, very good. So a lot of people subscribe to it. But don't forget, improvement in gas exchange does not mean improvement in mortality or morbidity. So there's no evidence that APRV is the gold standard for severe ARDS. It's a modality that can be used, but you need to remember that all these high settings comes with consequences as well. Mervyn Singer's group, all SIMD. I went there, I was like, I don't see our outcomes any worse than the Italians. Okay. Then the Italian colleagues will come, hey, Poh, no, we need to put him, APRV. They're like, okay, whatever, But there's nothing robust lah. So the main thing is that you need to understand the concept of what's going on. Personally, for me, my team will know if the patient comes in with oxygenation failure, I don't allow a respiratory rate of 20, 22, 24 because you reduce your respiratory cycle time. In 3 seconds, what are you going to do? 60 divided by 20 is 3 only. What are you going to do? Are you breathing 3 seconds all the time? Finish. So how am I going to manipulate my breath cycle? So most of the time, I keep it at 16, 18. Again, CO2 doesn't kill our patients. Oxygenation, poor oxygenation will kill our patients. So my inspiratory time for me, I need at least 1.4 to 1.6. I need to recruit. And again, the principle of fast and slow alveoli come in. You don't want to expire too quickly before your collapsed alveoli is even recruited. And then what's the point? Then you're just producing a cycle like this. And all you are doing is washing out your CO2. But don't forget, if your alveoli are recruited, your CO2 will improve, right? Your tidal volume increases. Your areas of compliance improves. So then you have better gas exchange. So high CO2 is not just about increasing your rate. You get what I mean? But that being said, don't be so fixed and say, some fella out there came for some talk and tell me I cannot increase the rate to 20. So it also doesn't lie. You have to look at the situation, all right? So finally, no choice lah. Prefer respiratory ECMO. Anyone done? Dr. Ijaya will be more familiar with all this. But my experience with ECMO, if you are in a resource-rich country, you initiate fast. And I think the outcome changes. In our center, you normally try until you cannot try, and then you convince the ECMO center, say, hey, please lah, take lah. And then they say, hey, no lah, too far gone. They cannot do anything. And the problem with respiratory ECMOs is they take time. The lungs are not like the heart. You take a patient with severe pulmonary embolism or massive PE and collapses, they put on a VA ECMO, they take over everything. Yeah, within 2-3 days can start to wean. But respiratory ECMOs potentially will take longer. And if you are in a resource-limited country, one ECMO patient will maybe take up double the team of nurses, potentially 2 beds worth of, in your ICU. So, and we don't have the resources to just initiate it like that. One of my colleagues was a emergency physician from Paris, and her expertise was pre-hospital ECMO. So in the streets of Paris, it's so narrow. Right? And then you watch movies where their houses are all flat, right? So narrow, then you climb up the stairs 2-3 floors. So what happens? They go on motorbike. Reach there, go up, initiate ECMO. Fire engine comes, breaks down the wall, and takes the patient out like that. And then they go to the hospital. So advanced. Taiwan is among the biggest use of ECMOs in the world, but just that because they don't publish in Western literature, after the earthquake, they even do it in private centers. So, but is it a modality that you can just throw about like that? One, I think the circuit itself, just to open it, is 10,000 ringgit. Right? And then you need to train your perfusionists, you need to train your nurses, you need to train. So ECMO cannot be done individually. I think it's an important teamwork. And then if your perfusionist or someone goes home or not around, then you don't know how to crank, you don't know how to deal with the consequences, then it defeats the whole purpose. So, how do we end in ARDS? So what do you take home? Actually, everything I say, no gold standard also. And it seems like I do, I don't do also. Right? So what are we moving towards? So again, understanding the physiology or whatever is going on is important. Knowing our endpoints and taking a step back is important. But in the world, what are people talking about? They're talking about personalized mechanical ventilation. And this was just a few years ago that came out in critical care. You talk about personalized medicine, right? So now even mechanical ventilation, you want to talk about personalized. How do you personalize mechanical ventilation? So you see the 10 things they want to talk about. So know your rationale, your tidal volumes, your driving pressures, your plateau pressures. They talk about transpulmonary pressures, right? They talk about the concept of mechanical power. So don't forget, these are concepts. where they say that the machine generates energy which is transmitted to the lungs, and the higher the mechanical power is, the worse the outcome. But how do we calculate it? Actually, it's not easy. And many of these researchers have their own formulas to come up with it. You want to have your alveolar recruitment, make sure your gas exchange is targeted, right? And like Dr. Ashraf said, I think he raised many good points. Good thing I asked him to talk for me. You see, all these, dead space, ventilatory ratio, oxygen transport, all these are the small things that will make a difference. Whether your circuits are too long, or is it because of sputum, or is your flow too low or too high, right? Again, first world, CT scan. How many times we're going to call for CT? Radiology is going to throw their shoes at us and say, apa ni, CT for everybody. So also cannot. And then don't forget phenotypes, right? Not everyone is recruitable. Not everyone responds the same way. All right? And then finally, understand your physiology. What are you trying to achieve when you initiate a treatment modality? Okay, so any questions? I think that's all. Enough of me talking, enough of you hearing me talk as well. Do you have any burning questions before I end my time here? I think all okay, right? You're just as confused as when you came in. Right. That's Lisa, intensive care. Okay, so with that, I end my time. Thank you very much for your time.